Well, thank you all for attending. I really appreciate your time today. My name is Tim Oppler. I'm a managing director at Stifel, which is an investment bank that is focused on healthcare. The topic that I was given was sort of like the landscape of healthcare. Like that could mean anything, right? I mean, like, I'm not sure why all of you attended because that topic is kind of boring, to be honest. So what I'm going to do is talk about what I think is interesting in healthcare going forward. In other words, some of you are investors, some of you are entrepreneurs, some of you are thinking about being entrepreneurs, some of you just think Indiana is a cool place to be and are sort of thinking about like, what do you want to do here? What do we want to facilitate? So what I'm going to talk about today are three trends that are going to completely upend healthcare in the next 10 to 20 years. And more importantly than those trends, I'm going to talk about how those trends create business opportunities. So in my job at Stifel, I listen to pitches all day long. I probably get pitched 5 to 10 times a day. Basically, people come to Stifel they never come by to say, hi, like, Tim, I want to meet you. It's never like that. I mean, they might say that, but they don't mean it. Everyone wants money, or they want to be sold, or they need to get some kind of deal going or something like that, or they just need to be connected. So that's what I do as a job. Essentially, an investment banker is a very fancy version of like a real estate broker. In other words, instead of buying and selling houses, you're buying and selling biotech companies or healthcare companies, that sort of thing. I only say that because in the process of being a banker for the last 30 years, I've also gotten kind of the bug of buying a few houses myself and selling them along the way. And so a lot of the topics that I'm going to bring up today are ones that I am personally investing in. So with that background, let's just go ahead and flip through a few slides here. I hope you can see them. So the three big trends I'm going to talk about, surprise, surprise, are first, AI and machine learning and how that's going to change healthcare. Second, obesity drugs, and much more importantly, the engaged consumer. There's a huge story this morning in the New York Times about what Eli Lilly is doing in obesity drugs and the consumers. I'm going to talk about that because Lilly is riding a very big wave that's much bigger than any one company. The third topic is value-based care. So in the old days, healthcare essentially functioned where you go to the doctor and the doctor would do a couple things to you and send you a bill for that. What we're switching to is a world where the doctor just gets a payment for you for the year. If you're healthy and you don't have to show up, they make a profit. If you're sick and you show up a lot, they actually lose money. And so in the world of value-based care, it completely turns the whole business model of being a doctor or a healthcare service provider upside down. And because of that, there are enormous opportunities in the world of business. And we're going to talk about sort of who is big now, but where I think it's going to go in the future. So let's go ahead and get started with AI and machine learning. And I don't know if any of you heard the last speakers. They were talking about AI in the field of Wall Street. I actually listened to the talk. I thought it was fantastic. And a lot of the same themes that are impacting AI in the world of trading are also relevant in healthcare. And I did walk around and listen to a couple different talks this morning, like every one of them is about AI. So I'm not going to bore you with a bunch of stuff about AI, but we'll go through just a couple of basic topics. So the first thing is that the growth of computing capacity is really the main driver of machine learning. And so there's a whole bunch of different definitions here, but the basic idea is that the computer can both learn and essentially predict what's going to happen next. That's called predictive AI. And then actually say, okay, I see all these patterns. Why don't I just go ahead and create something like computer, write me a book? And you know, you have to kind of tell like what kind of book, but it's actually pretty good at doing that. So that's called generative AI. And this is driven very much by the growth of computing capacity. And so the key idea here is people are focused not on AI, but really on deep learning. And what does deep learning mean? It simply means that you can essentially create a neural network that it looks at the relationships between all these facts. And it turns out that for various reasons, neural networks are extremely capable of essentially spotting patterns that we can't see. And so the previous talk was about sort of how do you spot patterns and prices of, say, bonds and then take advantage of that. So what's a foundation model? A foundation model is a form of artificial intelligence that essentially takes a bunch of relationships that you spotted, say, in bond prices and creates a generalized model of, say, how the bond market works. So if you will, when we go to elementary school and we learn how to read, and then we learn a little bit about math, and we learn how to play in the playground, we're essentially building a foundation model in our head. In other words, we have all of this information about how math works or about how English works, that sort of thing. We learn to speak languages. We're essentially building a model. So the computer can build a foundation model, and those of you that have used large language models like ChatGPT are essentially tapping into a foundation model. And foundation models are really important in healthcare. I don't think we've really begun to sort of realize just how big they are in healthcare. The next thing I want to talk about is just the size of the AI opportunity in healthcare. And so one analyst says that by 2030, the economic value of the opportunity of doing AI in healthcare is around $280 billion. I think it's fair to say that in time it will be a multi-trillion-dollar market. It's absolutely gigantic market. The healthcare market itself is a $4 or $5 trillion business in the United States. So what I'm saying is a lot of healthcare is going to become AI. So this is an article that's a little hard to read, but from the New England Journal last year, that's just simply surveyed the adoption of AI so far in healthcare and said it's really nowhere. So healthcare AI is more of a concept than a reality today. And of course, that's good news if you're an entrepreneur. Here's a quote from an article that was published by Microsoft. And I thought it was a very good article, so I'm going to just talk a little bit about their analysis of the UK's National Health Service. And they note, for the NHS, the application of technologies has the potential to release time for care back to healthcare professionals, enabling them to focus on what matters to their patients in the future. In other words, the current vision of AI in healthcare is that it's a way of letting the doctor free up the time that they waste. That's kind of appealing to all of us, right? We all spend time during the day doing stuff we don't need to do. Like, wouldn't it be cool if you didn't have to take a shower in the morning, you just snapped a button and AI would take the shower? Unfortunately, that doesn't quite work. But, you know, there's all sorts of things that AI could do to give you back time to allow you to do better whatever you wanted to do in your life. This is, I think, a more realistic view. So I attended a conference where John Doerr of Kleiner Perkins spoke. He did not put this in the public domain, but basically he said, if you really look at what AI can do, where it's going to make a difference is you don't need doctors as much. Doctors essentially are just people that are walking around with this really complicated model of health, and they meet someone with a cough and they go through a process called differential diagnosis to try to figure out why they have a cough. And then once they know that information, then they go ahead and say, okay, take this pill. Well, the computer can do that. If a computer can trade bonds, they can definitely do that. And so what Doerr says is that, in 10 years from now, the number of doctors that we're actually going to use is going to go down by like 50%. I think that's probably true. And so we haven't really begun to absorb what AI is going to do to healthcare. So I want to talk about the London taxi, and I'm old enough that I've been to London and taken a cab back when they were like really cute. They're all now all these modern taxis. I'm sure some of you have taken the London cab. And you start talking to these cab drivers, and they're very interesting people, and you learn a lot about the country from talking to cab drivers wherever you go. So what you find out is that in London, even today, you're not allowed to become a licensed cab driver until you learn what's called the knowledge. And essentially you go around with someone else who watches you and says like, let's go from St. Pancras to Hampstead, and you've got to solve in your head for like the quickest way to do that. Well, it takes 2 to 4 years to learn this thing called the knowledge. And it turns out that it's too hard. Like there's so many ways to go from any one place to another place that no human can figure that all out. So they actually cheat, and they have what are called 200 sort of shortcuts around town. And if you follow one of those, you're generally going to get there. So anyway, that's what London cab drivers do. In 2005, there was something that showed up called the sat-nav. And the sat-nav is what we call GPS or Google Maps. And sat-nav, you just say, hey, I want to go from here to the Indianapolis airport, and I want to drive there, and it'll give you the quickest way for right now. Well, obviously, you don't need the knowledge anymore. Like, how long does it take Google Maps to tell you how to get from here to your house? Like, 10 milliseconds, right? So the computer is really, really fast. And so I just want to make a few comments about what happened in London is the Garmin, which is what initially came on the market, was able to match years of human learning because it's a very structured problem. There's only so many streets. The streets all connect. There's a certain speed. You can actually measure the average speed to go down this street and that street at a certain time of the day and so on. So it's actually a very solvable, bounded problem, but it's a big problem for our brain, but it's not a big problem for the computer, right? And so I want to call this a medium dimensional problem. In other words, the computer can easily handle that. So this is what happens if you take a bunch of NVIDIA chips. In this case, there's 80 NVIDIA chips, and you put them all together. And so in England, they did this, and this was sponsored by AstraZeneca and a bunch of other places. And the idea was to get this incredible amount of computing power. So this is about as good as you can do today with the computer. And this is called a 400 petaflop supercomputer. And it is an amazing computer. Like it could get you not just around London, it could get you around the entire universe probably pretty quickly. So we're going to come back to this in a moment, but I do want to make a couple comments. Where is AI not working in healthcare today? The first place is drug discovery. So I don't know how many startups there are doing drug discovery in healthcare with AI. I would guess there's at least 200 to 300 of them. Some of those guys have been around actually now for 10, 20 years. There's not one company that has done a quicker job or a better job of delivering drugs by essentially using the computer to discover drugs instead of some scientists over at Eli Lilly. This morning I took a walk around Indianapolis. It was kind of cool this morning, but by the time the walk was coming to an end, it was getting very hot. And I did walk right past Lilly Research Laboratory. So there's people in there right now with their test tubes or whatever they do, trying to come up with a new drug for all of us to use in the future. Those folks are doing just as well as the computer. So that's clearly not London cab driver type situation. Another interesting situation is a bunch of companies have been trying to beat Wall Street. So there's all these people that buy and sell biotech stocks and try to make money doing it. And so a bunch of folks said, well, what makes stocks go up or down is when the clinical trials fail or succeed. And so people started creating all these engines to do it. And a lot of very smart people started doing it. I ran a contest where I pitted a bunch of them against humans, and guess who won? Humans. The reality is the guy will come in and say, hey, this computer can predict the outcome of clinical trials 88% of the time. Well, basically, all trials in Alzheimer's fail. Pretty much all antibiotics work, so it's actually not that hard to get to 88% accuracy. And so that doesn't work either. Competing against doctors and hospitals is a different problem. So a lot of folks are like, look, we're going to put AI in the IU Medical Center, and they're going to, the doc will have some, person walking off the street with an iPad, ask the patient a bunch of questions, then the doc will come in at the end. That idea does not work. So London cab drivers still use the knowledge to get around. They do not use GPS, but there's a competitor that does, called Uber. So anyone can become an Uber driver as long as you're a safe driver and not a criminal. Uber will let you drive around town, right? But you're just going off the GPS. So anyway, there's this giant battle between Uber and the London Cab Driving Association or whatever it is, and Uber lost. And so that's essentially what's going on with doctors right now. So if you go into the New England Journal of Medicine or JAMA and just start reading up on, what did doctors think about AI? They must really like this idea, right? They hate it. Every single article you'll find is a doctor telling you why AI is not going to work. So if you want to go and start to replace doctors with AI, that's going to be a hard thing to do. They have too much power, and the reason is doctors control the state laws, and so there's all these state regulations and laws that essentially make it very difficult to do new things in healthcare. So this is just a slide that was published by a professor at MIT and just showed that if you're trying to essentially synthesize all possible small molecules, it's about a 10 to the 60th problem. So this comes back to those petaflops. So you would need, billions and billions of those petaflop machines that I showed you before to be able to solve a problem of this scale. So this is a high dimensional problem. So AI cannot solve for a high dimensional problem right now. It can only solve for medium dimensional problems. You might say, well, like, how can ChatGPT be so good then? Well, ChatGPT is actually solving a medium dimensional problem because there's only so many words that will follow any other word in our language. And so it's actually not that much worse, say, than driving around London, as an example. So this is a very interesting study. This was done in Israel. Israel is a fantastic country for studying healthcare, and that's because it's, first of all, it's a nationalized healthcare system. Second, they collect data on everything and everybody. It's not that big of a place. And so by doing that, they've been able to essentially build very good primary care AI algorithms. And what this study showed that was published last year in the Mayo Clinic proceedings is that in primary care, the computer just absolutely slaughters doctors. In other words, if you walk into primary care and there is that person with an iPad and they go through a diagnostic set of questions, they will do a better job of differential diagnosis on average than a physician will do. And like, it's not even close, right? So computers can definitely do a better job than doctors. So let's get to the punchline. What are the opportunities in AI? I mean, this is just a huge place to be investing in the future. And so I just want to identify 3 ideas that have struck me. The first is that foundational models are interesting in and of themselves. So like, let's just say you built a company that just made a foundational model of the kidney, right? Any pharma company that wants to do something in the kidney, any physician that wants to do something in the kidney, if you had a really good foundational model of the kidney, that could in itself be interesting. So there's all these AI companies out there right now. There's a ton of them. They're all really interesting. But I keep reading like what they're doing. No one is actually building foundational models that are specialized enough to be useful. So in the same sense that ChatGPT can essentially have a really good conversation with you, it should also be possible to essentially analyze everything there is to know about a piece of biology or an organ system. Maybe the brain is going to be a little bit too hard to do, but most organ systems, I think, present medium dimensional problems. The second opportunity that I want to identify is this notion of going back to that Israeli system. Well, it turns out most people in the world don't have good health care. In other words, most of us in this audience can probably go in and get good health care from our primary care doctor, I hope, but most of the world does not have that. Even in the United States, the bottom third of the population actually has pretty lousy healthcare. Even if you're in Medicaid or Medicare, the healthcare quality you get is not very good. I can speak from personal experience because I have a business that's doing it. And like, you just come back, like we just visited a housing project in such and such state, and we found that 70% of the people had a major undiagnosed, never seen before case of heart disease, diabetes, or whatever. So the quality of healthcare in the United States on average at the bottom is really bad. And so the idea here is, if you really could walk in with, say, someone who just got out of the Army as a sergeant with an iPad, the person's responsible, they know how to show up on time, and the iPad tells them what questions to ask the patient, that person could, in fact, do a really good job of interacting with someone who does not have good access to healthcare. And so to me, the idea is to not compete against the current medical system, but just to go around the system. And in fact, in most areas of innovation typically will start where the current system can't deliver whatever it is that you want to do. The third idea I wanted to talk about is artificial agents. I recently met with a venture capitalist that's investing in a bunch of these ventures. I said, so what's the most exciting idea involving AI in healthcare? And so he started to explain that essentially there's this never-ending battle between every doctor and every insurance company that essentially pays for those patients. So essentially, the insurance companies create all these prior authorization requirements, and then they require all this paperwork to be filled out. And so doctors are drowning in paperwork. So what one healthcare system has done, which is Northwell in New York City, is they adopted this system where the computer is actually much better at writing up prior auth requirements. So the insurance company is hoping you screw up the prior auth paperwork and say, well, we would have done it, but like you missed, paragraph 16. So the computer gets it right. And now the the insurance companies are like, wait a minute, oh, we've got a problem here, which is Northwell is like getting every prior auth correctly because they're actually trying to ration care with an excuse. And so the use of agents that essentially computers can learn, to do pretty much anything. And so that's a very structured problem to respond to a prior auth requirement. And so I think the power of agents in dealing with the paperwork burden in healthcare is going to be mind-boggling and will be very transformative, I believe, to what's going to go on. So anyway, I've wrapped up the first topic I had for you today, which is AI. I hope you get a flavor that there is a lot of opportunity. The second topic I want to speak about, which is very important here in Indianapolis, is the role of obesity drugs and what obesity drugs have meant for the consumer. And again, just this morning, there was a big story in the New York Times about what Eli Lilly's doing with Lilly Direct. So let's talk a little bit about what's happening in obesity. The first thing that's important to note is both tirzepatide, the Lilly drug, and semaglutide, the Novo drug, have been absolutely transformative to healthcare in the United States. And essentially, most Americans, I shouldn't say most, but something like half of Americans are over a BMI of 27. And so that's clinically not good for you. You're going to have a much higher probability of having a heart attack, much higher probability of having type 2 diabetes, and so on. And so with these drugs, finally, you can actually control your weight. In contrast, all the stuff you've been told all these years, which is to eat right, have your spinach, make sure that you exercise every day. Like, people say they're going to do that, but they don't. So this is a big deal, and I'm not going to tell you anything about this that you don't already know, except what people are not so focused on is the role of the consumer, how consumers are changing healthcare. I do want to just point out that if you look at the change in market cap of the top pharmas since the peak of the pandemic, which was February 7, 2020, what you'll see is Lilly and Novo have gone up by about $1 trillion in value. And a couple of the other companies that have come up with big drugs, like Merck and AstraZeneca, have also picked up 100, 150 billion in value. The rest of the big pharmas in general have actually lost value. In other words, the pharmaceutical market has switched to focusing on what I like to call big drugs for big diseases, or go big or go home. So that's a big theme in pharma, and I'm not going to dwell too much on the pharmaceutical industry today, other than to say that essentially obesity drugs have been the story, really, of the pharmaceutical industry for the last 4 years. So this is the next generation of approaches to obesity, and this is not a science lecture, so I'm not going to take you through, the benefits of a CB1 versus an Apelin, but let's just say there's a lot of innovation coming. And I did want to focus you on one company and one study. So Regeneron is running a study on muscle preservation. So they're using a new approach to generating muscle, and they're running a very large-scale series of studies in muscle preservation. And so this press release, and there's always 1,000 press releases every day. I just was reading this a couple months ago, and I about fell out of my chair, and I just want to share with you just to make sure in all the information you hear that you heard this one tidbit of information. So with what's called a myostatin inhibitor, Regeneron was able to achieve a change in thigh muscle volume of 7.7% with a combo and 4.6% with the myostatin inhibitor in a period of 8 weeks. So think about that. In 8 weeks, you can increase your muscle volume with one drug, the myostatin inhibitor, which is known to be a relatively safe approach, by about 5%, which means over a year, you'd think that's like 20, 25% change in your muscle. Well, you've actually been able to do stuff like this for a long time, but it's involved illegal drugs. So you hear about like all those anabolic steroids and stuff, like, well, we don't do that because that's really unsafe. But now there's something out there that will allow us to bulk up. The last 10 years we've learned how to lose weight. Now we can soon bulk up without actually having to work out. Okay, so that's something I just want to highlight for you, is really changing scientifically. So these are some pictures I generated with AI thanks to ChatGPT. And so on the left is a picture of the typical male American, middle-aged male American in 2010. Today in 2024, that guy has figured out Zepbound. He's on his Zepbound, and boy, he's looking a lot better. I initially made photographs like this of women shopping in Park Avenue. This is because my mom said, what happened to all the fat women on Park Avenue? They're just gone. They're all on semaglutide. There are none left. And our compliance department said, that's a little stereotypical. So we switched them to men, and it takes about 2 seconds to do it in ChatGPT. And then what I want to point out is by 2034, we're all going to be able to bulk up and look awesome without actually having to work out. So think about what's going to happen in the field of pharmaceuticals. I guess what I'm trying to say is obesity drugs are big now, but you haven't seen anything yet as to what's going to happen. We're all essentially going to be able to look like models in 10 years, I think, if the Regeneron data holds up. Lilly's drugs are getting much better, so their next generation drug, as you would imagine, is going to be a lot better. And they're also into this muscle stuff, as you would guess. So what's happening now is that the obesity market is being taken over by the consumer. And maybe just to make a point, this happened before. So I don't know if you remember, everyone was being told to quit cigarettes, and then the state started like making your nicotine gum free if you wanted to quit cigarettes. And of course, people would chew their nicotine gum and then they'd still keep smoking cigarettes. It didn't really work very well. And then the FDA came out and said, you know what we're going to do? We're going to allow companies to make artificial cigarettes, these things called nicotine inhalers, and they created a whole regulatory pathway. I'm a banker. I looked at it. It cost about $150 million to get a nicotine inhaler approved. They created all these regulations. And all of a sudden, one day, you just start seeing nicotine inhalers like in the 7-Eleven. And today, that's a gigantic market. In other words, the consumer would rather not smoke cigarettes, but they are, of course, addicted to nicotine. And so a nicotine inhaler allows you to replace the cigarette with nicotine. It should be very good for you. And what I'm trying to say is this is essentially what's happened to the obesity market, is the consumer is finding if you go to Medicare and say, hey, I'm overweight, really sorry about that, or you go to your employer and say, hey, does our plan, United Healthcare, cover my obesity drug? The answer is they don't. I spoke to a senior person, one of the large managed care groups, and said, why don't you cover obesity drugs? And his first argument was we'd go broke. And I said, you're going to actually save lives if you do it. And he just said, look, we don't reward people who eat chips and stuff. Like it's seen essentially as a moral failing, kind of like we all saw alcoholism maybe 50 years ago. That's sort of the mindset of these payers. And so all I'm trying to say is, as a result, the consumer said, the hell with this. I'm just going to go get my Ozempic on my own. I don't know about you all, but I'm a banker in the pharma industry, so I'll sit down with my cousin somewhere, hey, what's going on in your life? Can you get me some Ozempic? That's all people want to talk about. And the entire country has gotten interested in Ozempic. And the US government does not pay for GLP-1 agonists unless you have type 2 diabetes. I actually have a personal story. A family member of mine was getting stents this week. She's overweight. I said get on Ozempic. She's in Medicare. They don't cover, she's not diabetic. They don't cover it. And so it's a problem. So what's happened is the private pay market here is now much larger than that e-cigarette market. I say that because I'm an investor in some companies in this space, and so I have kind of there's no data out there, but it's a very big market. And just to give you one chart that was put out by the Kaiser Family Foundation, 79% of people that are using the GLP-1 today got it through their doctor. It turns out that even this direct-to-consumer market is going through doctors. So at least 21%, I think it's more like 30, maybe 40% of the obesity market is now essentially driven by the consumer seeking the drug on their own, as opposed to the doctor coming to them and saying, hey, Tim, I think it's time for you to get on that semaglutide. That's a very interesting change because this is a giant market. What I'm trying to say is for the first time, the RX market, consumer market, is really being impacted by consumers. The consumer is essentially taking over their care. It is driven by aesthetic considerations, of course, not healthcare as much as maybe it should, but it's my belief that this change is actually very threatening to both the pharmaceutical industry, but much more threatening to those that are essentially trying to control access to pharmaceuticals, including the US government through the Medicare system, Medicaid system, and also to the existing insurance companies. Like, why do you have health insurance if they won't cover your obesity drug? It's the one drug that most Americans actually want. So by my calculations, this market size here, just using some recent data, will end up being over $100 billion. That's getting close to the iPhone. So once those muscle drugs hit, where you can essentially take off weight, pharmacologically become super fit, this market will be bigger than the iPhone. The iPhone is the largest single consumer product out there. We should talk a little bit about Eli Lilly and where the business opportunities. So Lilly understands all of this, but they're a fascinating company. They're a research-driven pharmaceutical company. They'll proudly tell you that. I once spoke to someone at Lilly. They used to own Elizabeth Arden. I don't know if any of you'd have to be pretty old to know that. So that was back in the 1970s. They sold Elizabeth Arden. I said, why did you sell Elizabeth Arden? They said, people don't care if it's better cosmetics. They just care about how you advertise it. Well, what's going on today in obesity drugs, and I see this again through a business that I have an ownership stake in, is this like, how good is your TikTok influencer? Somewhere around here, there's like a talk, that's all about influencers. It is all about influencers. In other words, it's how you market the drugs on TikTok that actually drives your sales. And what people are doing is that they're segmenting the market. So Chinese people that are overweight, or African American young women who want to be better looking, you pick your market. And so we're seeing just more and more websites pop up that are really targeted to the audience and really speaking to the audience using influencers. And so what we're finally seeing is that the biggest pharmaceutical market that's driven the entire pharma market is essentially being taken over by consumer marketing. I think that's a huge change, and it's one that raises numerous business opportunities. So just to list off a couple of business opportunities. First, why not just get a second-tier GLP-1, get it approved, price it for the consumer? So the consumer price today for a GLP-1 per month is about $150. Lilly, with great fanfare today, said, well, we'll get you a vial of tirzepatide for $550 a month. That's much more expensive than the consumer market. The second would be these muscle-enhancing drugs. The third is, I do think that more consumer marketing of drugs that already exist is a big opportunity. And the fourth is, I do think that there's a big OTC market. So most of us would rather not use a prescription drug if we don't have to. And so today's best consumer OTC drug for losing weight is Ally. You lose about 4% of your body weight in about half year. It's just not very impressive. So there's a company in Sweden called Empros that can get that up to 7%. I don't think it would be that hard to improve on that. So to me, that's a big business opportunity. There's a much larger opportunity, and if you look at what's coming out of some of the big VCs like Andreessen Horowitz, General Catalyst, they're really talking about how is healthcare going to change in the next 20 years at the level of the consumer. In other words, if the consumer is taking over responsibility for their healthcare, what does that actually mean for our society? And so I view this obesity area as kind of an entree into something much larger, and that is a way of allowing consumers to customize the care that they receive and to essentially access the care that they need for their families. And so I do want to show an article to you, which is put out by Daisy Wolf and Julie Yu from Andreessen Horowitz. And they essentially wrote an article. They wrote a couple of articles. So the first article was called The Biggest Company in the World. And they simply said that there's going to be a company that's much bigger than Amazon or Microsoft, and that's going to be a healthcare company. But it's not going to look anything like Eli Lilly or United Healthcare. That company is going to essentially connect consumers with health. I think they're right. And so this is the big opportunity and kind of coming out of this whole conversation about what's going on with obesity drugs. And so they argue that a consumer health tech company will become the biggest company in the world. And they really go through in the article, and I encourage you to read it, sort of the ability to connect doctors with pharmacies, with people, with AI. You can sort of see where this is all going based on my talk today. I did want to share one quote from Bob Nelson, who's a very well-known venture capitalist, and he actually put this up on Twitter. I just thought it was a very interesting quote. I happen to agree with him. He writes, I think the biggest company in the world will be one that can invent technology to prevent or reverse disease, or both, and vertically integrates like tech has done to own the entire care system, disintermediating hospitals and pharma better for people. He's got it. So this is what I think is going to happen. So I am myself an investor in this kind of stuff. I mentioned I do some startups. And what I'm doing is, instead of trying to do the whole system, I literally picked a single disease that's very poorly handled today, where the patients are out there on social media, and we're just going after one disease. We're essentially displacing all the care providers, we're displacing all the payment system, and essentially just going after the patients, and so far it's working really well. So I think this concept is a very viable concept. The third topic I wanted to hit quickly is value-based care, and just to comment, the value-based care is, again, this idea that in the future, instead of paying for the episode of care, systems will instead pay for the patient. Or let's say a patient comes along that's a more expensive patient, someone with heart disease or type 2 diabetes, they'll pay a higher price. And so the way it works today in Medicare is that CMS has introduced a program called Medicare Advantage, where people essentially on the provider side get paid fixed prices. And value-based care models center on patient outcomes and quality measures, such as reducing hospital readmission. So this is a huge change in our system. If you go talk to the typical hospital system in the United States right now, they're just hoping this doesn't happen to them. So I've been talking to a lot of health systems and so on the last couple of years, and most of them have yet to feel the real impact of value-based care, but that's going to be changing. Health and Human Services has a goal of getting 100% of Medicare to value-based care. Most of healthcare dollars are spent in Medicare. That's 65 plus people. They're more likely to get sick, and so that's a huge change in the United States. Basically, the way Medicare Advantage works is there's a fixed payment per patient per year that is set based off codes that are disease specific. And what's happened is there's one company that really understood this early, and that's United Healthcare. So United Healthcare sort of picked up on this, and they did something that I didn't understand at the time. So, like 25% of America uses United or Oxford. And what they started doing is they started buying doctors' practices. And the idea is a very simple one, which is in Medicare Advantage, you get paid a certain amount, say for a diabetic, say $18,000 a year for a diabetic. Well, you're actually only allowed to make a 15% profit margin. So if you end up being able to much better treat that diabetic, what you're going to do is you're going to actually give that money back to the patient. Is how Medicare works. Kind of cool, actually, I guess. Well, that's not profit maximizing at all for United Healthcare. So what they realized is if we bought the doctor, and we own the doctor too, then we just pay the doctor more. So they're just making care more efficient and then leaving the money with the doctor, which, funny enough, they own. So it's an absolutely brilliant model. The problem is that healthcare in America is now becoming highly corporatized. So at this point, maybe just to show you some more data, we are seeing 17% of physicians in the United States working for value-based players, Optum and CVS. There's a story in the Wall Street Journal this year, I guess Optum is up to 10% of all doctors in the United States. I mean, that's a stunning statistic. 83% of physicians still work in multi-practice systems or the community. And so in the future, over a third of doctors are going to be working for these value-based care players. And a lot of doctors are just leaving healthcare. They do not like this at all. And it's because once you work for Optum, you're essentially told how you're going to take care of patients. You're going to take care of patients in a way that minimizes cost while delivering a certain level of care. Optum is definitely not trying to skimp on care, believe me, but they want to deliver the care that they want to deliver at the lowest possible cost, as you would think in this value-based care system. Value-based care dramatically changes the incentives in healthcare, and these are just a list of some other companies that are really doing, I think, a pretty interesting job now of innovating in the value-based care arena. So they did a survey recently where they asked people who run healthcare systems, like, what worries you? Overwhelmingly, people said Optum worries us. So Optum is coming for you if you're running, a healthcare system today like Ascension or whatever. They are a problem because they're completely changing the model, And they're essentially inserting value-based care in all the various regions of the United States. These are some slides that for you are more or less unreadable, but maybe we can figure out a way to distribute the slides to those of you that want. And essentially what these slides say is that Andy Whitty, who runs United Healthcare, is saying we can grow at 15% per year indefinitely. So I guess the question I'm having to ask you, here we are at this Rally Innovation Summit, and we're looking to innovate, is where is the innovation opportunity? I would say the innovation opportunity is to outdo Optum. So Optum, doctors don't like it. The patients don't love it either. If you talk to people that end up with Optum, they don't, and I'm not trying to criticize Optum, I'm really talking more about the concept. They're all good people, of course. And I guess what I'm trying to say is I think there's a huge opportunity in this space to essentially come in and innovate. And so I'm going to just try to give you a little bit of a flavor for that, and then I'll wrap up. The first thing I think that's important to note is that almost all of the expenses in the U.S. healthcare system for 5 chronic diseases, congestive heart failure, type 2 diabetes, those kind of diseases are essentially where most of the expenses go. 95% of Medicare dollars go for managing long-term healthcare conditions. And so the first idea I want to kind of bounce off of you is that the idea that diagnostics can change healthcare outcomes. There's a fascinating paper in Nature Medicine just 2 weeks ago that essentially used data from the UK Biobank, and they showed that you could pretty much predict with more than 95% accuracy most diseases that people are going to have in the next 5 years. So imagine that. Some patient comes in, they're a 68-year-old person, Medicare, and you can take a vial of blood, send it off to a lab, and know pretty much what diseases they're going to have. Think about what that means in the context of AI. It's an incredibly powerful thing. So today, the labs that are being used in medicine are typically based on technologies that are 20 to 25 years old. So the ability to innovate in diagnostics, I think, will be transformational in this field of value-based care. I would make a further comment that there's a very interesting company out there right now called Grail. I don't know if any of you have heard of Grail, but Grail will take a vial of your blood and tell you if you have cancer or not. It's a pretty good test. I mean, we should all do it, except it costs $1,000. So the Grail test will tell you if you have cancer if you have cancer, it'll tell you if you have cancer with basically 60% probability, which is pretty good. I mean, you'd like it to be 95%, but I mean, if I have cancer, I would like to know. So, I'd pay the money. What I'm trying to say is in the future, you're gonna be able to take a test that will tell you if you have any disease. That's what this recent paper meant. And so think about what that means in this value-based care context. So let's say you're like the one guy out there that has this insight and, United Healthcare hasn't gotten around to it and CVS is too busy with whatever problems they have. There's a giant opportunity, I think, to essentially figure out what problems your people are gonna have and get on them early. And that's what value-based care is supposed to do. So just to give you one very simple example, atherosclerosis, one of the most common problems, heart disease, your arteries get clogged. So today, if you go to the doctor will talk to you about your HDL and your LDL. An investigator at the Brigham and Women's Hospital, Paul Ridker, has said, if you just looked at one other variable, C-reactive protein, or better yet, IL-6, which kind of measures the same thing, you will be able to much better diagnose who's going to have bad outcomes from heart disease. So you'll hear this all the time. I had a heart problem and my LDL was fine. Well, that's probably because there was something else going on. And so in this chart that's shown on the upper right, what Dr. Ridker shows is that inflammation is more predictive of bad outcomes from heart disease than LDL. And I'm just trying to make the point that there's plenty of room to innovate in diagnostics. So the idea would be in the future, there's going to be a model that is much more neural net-like, and what I'm suggesting is you come in to see your doctor. The doctor is looking both at physiologic states, what my cholesterol might be, and it's also looking at a host of sub-physiologic states. The computer is sort of saying, Tim needs to do this, this, and this, and the doctor will then essentially provide those prescriptions to me, which would include potentially a series of pharmacologic interventions. I want to introduce 2 key words, and you'll hear these all the time if you read healthcare stuff. The first is the concept of an accountable care organization and an ACO. An ACO can contract with the U.S. government and take on risk. In other words, I'll say, okay, I will take 10,000 type 2 diabetics. Okay, I'm getting $18,000 a year. if I can deliver good care to them for $16,000, I'll make $2,000 per person. In contrast, an MSO, or what's known as a managed service organization, can subcontract with an ACO and say, you know, you're making $2,000 per type 2 diabetic, I'll take them off your hands, you don't have to do anything. I'll take them off your hands you just have to give me $1,500 a patient. So that's what an MSO does. So one of the big business opportunities is to do MSO. So what's going on right now is an MSO is essentially a union of physicians. So the physicians essentially hire an MSO to go contract on their behalf with payers. And so one company that I know very well is called RioMed. So RioMed essentially is an MSO in Southern California. More than 80% of all nephrologists in Southern California joined RioMed, this MSO. They just went to all the payers and said, hey, so it's $190,000 a year you get for someone in dialysis. You get $88,000 a year for someone with CKD4. We'll take care of those patients for you. Our price is, say, $70,000. They can actually do it for $40,000. So it turns out that kidney care isn't that hard. So most of the expense in kidney care is caused by needless mistakes. And so what RioMed does is just essentially fixes those by better uses of nurses and so on. So that really wraps up my talk, and I think I've covered sort of three key themes of innovation for the future. The first is AI, huge opportunities. Second is the rise of the consumer, which we're seeing in this obesity market. And the third is value-based care. And just to make one last comment, they all kind of fit together if you sort of really think about it. I really like the paper that those folks wrote out at Andres and Horowitz. So just want to thank all of you for your time today.